Welcome to this OncLive News Network presentation, broadcasting live from the MJH studios. Today's discussion will be focused on the treatment of locally advanced lung cancers and evolving treatments for these illnesses. I'm your host, I'm Mark Chris. I'm a medical oncologist and I work at the Memorial Sloan Kettering Cancer Center in New York. Today I'm joined by two friends and colleagues, Dr. Jyoti Patel, Professor of Medicine from the University of Chicago, and Dr. Walter Curran, Professor and Chairman of the Department of Radiation Oncology at the Winship Cancer Institute of Emory University in Atlanta. During the next 60 minutes, we're going to navigate through some of the questions surrounding exactly how we treat patients with locally advanced lung cancers. We'll discuss multidisciplinary care and consider how the availability of immunotherapies will change the treatment landscape going forward. During the last few minutes of the broadcast, we'll answer questions related to this discussion as submitted by the audience, and we invite you to submit questions using the entry field located below this video. In the first group today of issues we're going to talk about, what are the treatment goals for early stage lung cancer? I think that's a really good starting point. Jyoti, would you like to lead that discussion? What are the goals of treatment for early stage cancer? Compare and contrast it to other groups of patients?
Sure. So we will see, unfortunately, still a minority of patients with non-small cell lung cancer who present with the earliest stages of disease, stage 1 and 2. And by and large, those patients are patients who've undergone lung cancer screening or who picked up because of serendipitous testing, and we find that they have a solitary pulmonary nodule. Those patients are treated with curative intent, by and large with surgery, but also sometimes with radiation. About a third of patients present with locally advanced disease, and those patients have regional and mediastinal metastasis. And those patients, again, are treated with curative intent. Again, it's a difficult process because patients already have had some evidence of cancer beyond the lung itself.
Well, you want to answer that?
No, I agree with Jyoti. It's a challenging disease. What's exciting for people to realize, and I think a lot of the lay community, even the medical community outside oncology, doesn't realize the progress we've made in improving the survival of patients with locally advanced disease. The median survival in the trials that we did 2 or 3 decades ago was under a year. Most trials for good performance status patients with locally advanced disease are well in excess of 2 years, even before the trials that are looking at immunotherapy. So the platform has improved. Some of it is not because we have newer therapies, but because I think the oncologists know how to take care of these patients better. They know how to deliver concurrent chemoradiation and manage the side effects. They know how to stage patients better. So the platform from which we're dealing with good performance patients is much better. Those with poorer performance status and comorbidities, the outcome is still pretty tough.
I would add to that that in addition to the supportive care, in which we've seen huge gains, there's also some kind of migration because of better staging, right?
Correct.
So
no question.
That we're looking at a different patient population than we might have 2 decades ago.
Yeah, I think one critical difference to the medical oncologist is we do spend the majority of our time treating people with more advanced stages of the illness, for which cure is very rare. Here, cure is not very rare,
right.
And the goal of therapy is cure. I think also when you focus on cure, it changes the dynamic between risk and benefit. I guess the best example, extreme example, would be a bone marrow transplant. Who would ever agree to a bone marrow transplant unless you know that it is a chance for cure? And I think here we have to be really careful to remember that, and that obviously nothing can be done without having a good understanding and agreement with our patients. But more risk is acceptable when there's that chance of cure. I think the other thing worth mentioning, and I've thought about this, about how many people are in this situation. The estimates are somewhere between 40 and 50,000 patients a year are in this stage 3 lung cancer newly diagnosed with stage 3 lung cancer. That's a very, very huge group. I mean, putting it into perspective, all of ovarian cancers is about 25,000 cases. Here, it's a huge number, and we have a chance to cure them.
And if you look at the 5-year survival rates from the 1990 trials, we're talking about 5 to 8% 5-year survival. The concurrent chemoradiation regimens, 12 to 15%. Most of the more recent trials are really in the 25% range. So that's a range not unlike what we saw with localized or limited stage small cell. So now we're dealing with other problems in long-term survivorship of such patients beyond the risk of recurrence of their own disease.
Absolutely.
May I ask each of you, what do you think the biggest challenge is right now for these folks? What kind of a therapy do we need to get more into that cure group?
So I think we are certainly making huge advances in our technology, and so we're delivering better radiation therapy. The integration of our chemotherapy backbone's improved. But probably I would argue that we need to do a better job of risk stratification. So we have really crude numbers or sort of ideas about how patients may fare based on performance status or weight loss or FEV1 or pulmonary reserve and comorbidities prior to enrollment. But even some of those patients we can cure, as you've said. And so knowing when to push the envelope a little bit for our patients, I think really looks, that's to me the challenge in the coming years in understanding either biologic basis of treatment and how to allocate more precise medicine.
Wally?
Yeah, and just to expand even further on that point, there's the risk of toxicity that we have to weigh. I believe there are some patients, and we don't know how to identify them sufficiently, who are probably at a prohibitive risk of treatment-related pneumonitis, for whom you shouldn't be pushing the radiation dose, and you should modify even the time-volume relationships. There's other people who may benefit based on tumor sensitivity from pushing the radiation dose, but we have inadequately identified them to know how to stratify them and identify them for radiation dose escalation. And those are parameters that are being actively studied. My view is we need to study those things more.
And to me, the greatest risk to our patients, though, in this situation is not the failure of the radiation, but the failure of the systemic therapy. I mean, we can discuss the role of radiation in controlling systemic therapy, but the vast majority of failures are not local. They're systemic or sometimes local and systemic, but it's a systemic therapy that we need more than anything else. Say a few words, too, about this group of patients with stage 3 lung cancer. I think the focus today is going to be on people that are inoperable and unresectable. I think there's no question, I think, in that group that those folks are best managed with a chemotherapy and radiation approach. And I'm going to play the role today. There's somebody missing from this. We have 2 medical oncologists and a radiation oncologist. We don't have a thoracic surgeon here. And I'm going to play that role as a wannabe thoracic surgeon. And to make it clear that there are some patients that clearly need to have surgery in their treatment plan. Also that how do we decide that? We need a clear discussion among all members of the treatment team, the thoracic surgeon, the medical oncologist, and the radiation oncologist. And I think we mutually have to come together and get the treatment plan worked out. I think the second thing here, moving on to the need to identify who is inoperable and who is resectable, I'm going to put it out there, the only person that can do both of those things, bottom line, is the thoracic surgeon. And I know in my own practice, I never take on that responsibility, saying who's resectable and who's operable. And I'd urge you to make sure that a thoracic surgeon that is part of the care team and makes those calls. Would either of you like to comment on that?
I would add a little bit more to that in saying that I think we need to do a better job in doing appropriate mediastinal evaluation. So in areas, I practice in the Midwest, there are multiple patients with things like histoplasmosis who may have mediastinal nodes that are enlarged but aren't pathologically proven. clear adjudication of N2 versus N3 nodes. So by and large, that's done by interventional pulmonologists who are now very much part of the care team through things that are minimally invasive, such as EBUS. But clearly, I think understanding sort of the mediastinal nodal status is paramount in adjudicating the appropriate therapy. Once we know which nodes are involved, most of us, I think, or very clearly, we can say patients with N3 nodes are unresectable. But beyond that, multi-station versus single station, clinically enlarged versus microscopic, I would 100% agree that truly the thoracic surgeon must be involved in that decision making.
And I think what I've learned in the past decade that I did not appreciate as well is the opportunity to improve a patient's fitness to medically tolerate surgery. There's lots of comorbidities in lung cancer patients, and if they are dealt with medically, and sometimes they can be dealt with by pulmonologists, cardiovascular, rehab physicians, people who have what might be considered a marginal state for general anesthesia and a difficult surgery can actually be rendered medically resectable, and that can be of tremendous benefit to the patient.
Prehab.
Yes,
In
rehab.
addition to rehab.
Yeah.
So let's talk about the management of the different local modalities first. And again, I'm going to be the thoracic surgeon here. Just to say that our ability to evaluate, to stage, and ultimately to resect has improved tremendously. I'm shocked as an observer to see people that have a thoracic surgery that spend one night in the hospital and take no analgesics. I mean, it's just an extraordinary thing. Now, again, that's not every patient, but they can do that now. And the whole metric on the invasiveness of surgery has changed tremendously, and also what is resectable and what's not. Pneumonectomy has just about disappeared, I know, from my institution by doing sparing operations, by doing sleeve resections. Things like a pneumonectomy are pretty rare. The other opportunities with surgery are the use of neoadjuvant and adjuvant therapy. We could spend the rest of this hour going on the advantages of neoadjuvant therapy. I'm a strong believer in that. I learned in my thoracic surgery training, and literally the thoracic surgeons at our institution are the ones that brought neoadjuvant chemotherapy into the forefront. And it's got some great advantages. It's better tolerated. And the beautiful thing about it is you know if it's working. You can tell often from radiographic studies, but then also you can tell from the resection specimen at the time of surgery. And you can plan therapy very carefully with that information. So with great opportunities in adjuvant and neoadjuvant space, surgery is an important consideration for a lot of patients with stage 3A disease, and I think there's consensus here in stage 3B disease. There's still no clear role for thoracic surgery. But again, please make sure that the operability and resectability questions are nailed. So Wally, could you just give us some thoughts, guidelines about optimal radiation treatment for patients with stage 3 disease, inoperable, unresectable in 2018?
Sure. We have a lot of tools available for radiation oncology management of these patients. And I'll just focus on those that are really should be in any department or any clinic that's really committed to those patients. We have CT-based treatment planning. We have what we call image-guided radiation, and we also have the tool of intensity-modulated radiation. Every patient should have those tools available, and the physicians may or may not always need to use them. Image guidance really allows a radiation oncologist to look at a patient whose target actually moves fairly significantly in the respiratory cycle, perhaps because the person just struggles with breathing in a quiet way on a table, or there might be other confounding factors. Historically, what radiation oncologists would do would be to give large margins of normal lung above and below the tumor, and therefore put the patient at risk for too low a dose of radiation or too high a risk of radiation-related pneumonitis. What we can now do is actually cycle our treatment delivery with the various phases of target motion. And while that may seem technically simple, it ends up actually requiring some fairly sophisticated hardware and software, but is well worth the effort. What intensity modulation does is allow some creative ways to go beyond just treating a tumor from the front and the back or from one angle or another, but really allows us to take into account the full 3, if not 4-dimensional contour of the target, the normal structures. So you can actually give the dose where the tumor is and reduce the dose to structures that don't need radiation, such as the heart, the spinal cord, and the normal lung. We had a very thought-provoking trial in the radiation therapy oncology group where we saw what we thought was a reasonable radiation dose escalation associated with poorer survival than a standard dose. And when we studied the results, we actually determined that it might be due to too high a dose to the heart. And those patients who had either image guidance or intensity modulated radiation did not have that high dose to the heart. So we see the tools. They're not always used in every clinic to the degree they had, but you really do need a committed team of radiation oncologists, physicists, dosimetrists, and therapists to really execute this work. Now, there's also a lot of excitement about what we refer to as stereotactic radiation, which usually involves a much higher single dose of radiation delivered 1, 2, or 3 or 4 times rather than over a 6-week course. Most of the progress in lung cancer with stereotactic radiation has been for smaller tumors, not for stage 3. But now there are trials. We had one at Emory where we're using the stereotactic boost as a stereotactic treatment as a boost dose to a quote-unquote cone-down volume. And I think we'll see that more and more. And the final area of radiation that's quite interesting is proton therapy. Proton therapy has demonstrated its ability to reduce normal tissue dose even better in some but not all patients than the intensity modulated radiation. And right now, in energy oncology, we have an NCI-sponsored trial comparing the intensity modulated radiation to proton therapy, all patients receiving concurrent chemotherapy.
Jyoti, can you say a word about the other component of this bimodality therapy, and that is the chemotherapy? What drugs, do you have go-to drugs and pros and cons of the different drugs?
Absolutely. So there are multiple chemotherapy backbones that are very reasonable to use. But probably the most accepted based on phase 3 data is cisplatin and etoposide. That can be challenging for some folks, getting 5 days of chemotherapy, but it's during radiation, and so that time overlaps. There is a large number of American oncologists who treat primarily with carboplatin and paclitaxel with familiarity with these drugs, and this is weekly. I think traditionally people who used carboplatin and paclitaxel also gave a consolidation afterwards with 2 cycles, sort of a full dose. And then more and more we're seeing a lot of cisplatin and pemetrexed based on the PROCLAIM data, which was essentially a negative study, but one that showed non-inferiority, essentially with equivalence. I think all of these are very reasonable. Most depend on patient and oncologist preferences. So cisplatin pemetrexed doesn't have alopecia, for example, and it's discrete. It's 1 treatment every 3 weeks. The carboplatin and paclitaxel has been widely adopted because of toxicity. I think it's a little bit better to So
I'm going to put you on the spot. Your go-to regimen for a patient with adenocarcinoma who's fit?
It's really evolved as we talk about this, but certainly I'd been using a lot of carboplatin and paclitaxel because that was the best data from the study that Wally was talking about. Really, I mean, that set a new standard, and I had shifted my practice and adopted in the past year or 2, but now with integrating immunotherapy, I think I might be doing some more cisplatin pemetrexed again.
And for a patient with squamous cell cancer?
I think again, I had been doing primarily carboplatin and paclitaxel, but it may evolve to cisplatin etoposide.
Okay. I have to say I've never been a fan of the etoposide because of its lack of single agent activity. I know it's been thrown into a lot of regimens. I in general always prefer to give 2 active drugs. Cisplatin would be my kind of go-to drug. Pemetrexed in the case of adenocarcinomas, and probably a taxane. Docetaxel, we've had a lot of use of that, but you could easily use paclitaxel or albumin-bound paclitaxel actually for a lot of reasons. Let's move on to the disrupting force in this whole area, and that is the Pacific trial. Wally, do you just want to say a few words about what Pacific is for those people that have not had a chance to see a medical journal in the last 6 months?
So Pacific's the term which refers to a 2-arm phase 3 blinded trial, which for patients with stage 3 disease published, the first part of the results published late last year in the New England Journal. So over 700 patients were enrolled in the study, which randomized patients after chemoradiation for stage 3 disease between durvalumab and a placebo with 2 co-primary endpoints, one being progression-free survival and the other being survival. And there was a 2-to-1 randomization ratio favoring the durva arm, and the results, which came out last year, showed a very statistically significant advantage in progression-free survival favoring the durva arm. Survival data has not been reported yet. I think most people expect it later in 2018. And if you look at every subgroup that we normally divide stage 3 patients into, there is a benefit favoring durva over placebo in the consolidation phase.
A question about the rationale for putting a immune checkpoint blocker with other therapies. Is there a particular reason why it would be a good agent to combine with radiation or concurrent chemotherapy radiation?
There's lots of laboratory data and what I would describe as growing clinical data that checkpoint inhibition is actually its activity is actually strengthened and accelerated by radiation. In this particular setting, it's not the classic experimental design where you give a full course of radiation, you have a several-week break, and then you give a checkpoint inhibitor. Most of the trials have looked at a closer temporal relationship and have actually looked then at responsive disease outside the radiation field as somehow evidence that the checkpoint inhibition has actually been helped by radiation. So this is not the classic experimental design of the so-called abscopal effect, but still what I think everyone who's looked at the data views as an extraordinary and landmark trial.
Mm-hmm. And are there any things about any trial design issues that you think need some further clarification or unique aspects of this trial? Well, in terms of the radiation?
Sure.
First.
It was different than almost every other stage 3 trial, particularly the phase 3 trials, in which because the registration and randomization happened after the chemoradiation, and it really was available for those patients who were basically non-progressors on chemoradiation. So all the guidelines regarding radiation quality, all the steps regarding the dosing and schedule of chemotherapy that really have become kind of part of the quality assurance of trials in Europe, Japan, or the United States were absent here. And when you have such a dramatic result, you wonder whether there was perhaps an uneven balance between the arms of risk factors for progression. Because, the arms broke very early, surprisingly early. I don't have an answer as to why that was the case, but, we will see other studies interrogating this issue. So I think we'll get more guidance on it. but there's nothing that's been available to the medical public to explain why or if there's any maldistribution between the two arms.
Yeah, also, I'm wondering too, though, is there something different about the early stages of lung cancer and their responses to checkpoint inhibitors? Again, I'm involved in a number of the neoadjuvant trials,
Right.
And I think people are very surprised at the profound benefit that we see, and not radiographic benefit, but pathologic benefit in those resection specimens.
Yeah.
There's that nivolumab experience presented at ASCO last year, about a 40% pathologic complete response rate with 2 doses of single agent nivolumab. And again, with chemotherapy in that setting, you'd expect about a 15 or 20%. And we're seeing the same thing now with atezolizumab. So it may be that there's something about having an intact tumor lymph node system that makes it more amenable to immune checkpoint blockade. Jyoti, any issues in this trial about the chemotherapy piece?
Sure. I mean, certainly I think the design of the trial at first, when we all heard about this, seemed a little bit reckless. What, no rules? You can do whatever chemotherapy you want. You just can't give consolidation. So again, for American practitioners who are so used to doing carboplatin and paclitaxel with consolidation cycles, I mean, this is a game changer. This reflects, I think, real world practice, right? So many patients are getting induction, and up to a quarter of patients did. Because of availability of radiation therapists in different parts of the world. So it may be that systemic therapy started earlier, but all treatment needed to be completed prior to randomization with no consolidation. And a wide range of regimens. And clearly the regimen didn't really seem to matter either. You know, when you look at subgroup analysis, the arms were well balanced, and it's almost dealer's choice. It's very much a real world scenario. Again, one that was surprisingly okay. And so, you know, how this sort of pans out in overall survival will, I think, be of interest. As markers, never smokers, the whole mishmash.
But again, it was a randomized trial, though. So again, the cross-trial comparisons are always tough. But this, we did have a comparison group here. Hey,
And the other thing that I'll say is, some people have commented that they believe the control arm had a surprisingly low progression-free survival. But keep in mind, there's a lead time difference between this and the typical cooperative group trials in that you're counting the time from, let's say, 2 to 10 weeks after chemoradiation as opposed to prior to radiation. So my recollection is the median progression-free survival is just under 6 months. So if you were comparing that to an RTOG trial, that would be more in the 8 to 9 month range.
Almost even up to 12 for some,
Right.
right? Because you could go up to 6 weeks after
Correct. That's
concurrent
correct. Yeah.
radiation. So
Yeah, that's correct.
So one other chemo issue in this trial is the use of chemotherapy after the immediate concurrent chemotherapy radiation piece. What is your normal practice now? Once you've completed the concurrent chemotherapy radiation piece, do you give additional chemotherapy?
Since this trial, no. I mean, you know, from patients who have landed in my clinic, it has changed, and have now decided to either treat with cisplatin pemetrexed or cisplatin etoposide, and really have abandoned a weekly lower dose approach with consolidation.
But are you still giving consolidation chemotherapy?
No.
Or no, this is and you replaced it. And I think that's one of going to be the largest impacts of this trial, is that the use of chemotherapy after the simultaneous chemotherapy and radiation piece of this multimodality program is going to go away. And for the record, there are clinical trials that show that additional chemotherapy, either continuing what you did before or switching to another non-cross-resistant one, did not improve outcomes and enhanced only toxicity. So this might be an additional benefit of this, is that limiting a chemotherapy, which is of marginal benefit, and some trials would say no benefit and actually some harm. What about a lot of folks have raised issues about the timing of durvalumab after the conclusion of chemotherapy radiation. Any thoughts you'd like to raise to that it appeared that people that started it sooner may have had a slightly greater effect of the whole regimen?
Yeah, and that's very clear, and it's a fairly dramatic difference. It's not a randomized observation, but it's an observation that I think is going to influence practice when possible. I think if people have recovered from the most serious acute effects of chemoradiation, I think the practice guidelines will look to starting it as soon as reasonable after chemoradiation. And I also am seeing that in the design of future studies, if the Pacific, for example, is the control arm of a study, looking to move that as early as possible. There's no evidence to suggest that toxicity is worse by doing that either.
Okay, so I'll ask you both the question: inoperable, unresectable adenocarcinoma and squamous carcinoma. Has this become a new standard for you to give concurrent chemotherapy radiation followed by durvalumab?
I always say, how could it not be a standard? I mean, with such a profound difference in progression-free survival, it has certainly had rapid adoption at my center, and we have started treating patients with it. Again, it's an interim analysis. Of course, I'm anxious about overall survival results, but it will, with such a big difference, it's going to be hard to really show a detriment in the other way.
Wally?
Yeah, I'd agree. Emphasizing that this is for good performance status patients who are able to get chemoradiation. This is unquestionably a new standard of care.
Yeah. I have to say that I'm more interested in the maturation of the progression-free survival curve, because only those people on the progression-free survival curve are going to be cured.
Right.
And I think that is the ultimate test here. Are we really going to cure more patients? And I'm really hoping that with more time, we're going to see those progression-free survival curves mature. And I do think it's changed therapy too. The other issue is, how many decades, Wally, have we been trying to do this? Maybe you're into the third decade of trying to do this. We've never succeeded. And in fact, in multiple trials, harm was brought upon by our interventions. Not trying to do that, but it happened. So this is really
yeah.
really
When you look, the last positive trials were the sort of concurrent versus sequential trials.
Yeah.
You really, and so those trials
I had
started.
a lot of dark hair then.
Yeah, exactly.
Yeah.
We all did. We all had more hair.
Jyoti always had good, nice dark hair. So what about something you might, obviously we're all using this regimen. Any tips you want to share, any kind of special issues that have come up so far in your treatment with this new paradigm? Actually, this is a pretty quick change. It's only 6 months ago. You weren't doing this, and now we are. So have you learned anything in those 6 months?
Well, I think the important thing to learn from the trial first is the adverse event profiles were only slightly different between the placebo and the durva arm. I think that, as you were saying, when you're going for a curative endpoint, you're willing to sometimes put up with worse toxicities. The toxicities, as reported, were not significantly worse. So that I think surprised a lot of people.
Yeah, I think it did.
And I think right now, the same guidelines that people are using to deal with any of the checkpoint inhibitors and their toxicities would apply. I've not heard of any unusual effects in this cohort as opposed to those getting this treatment for metastatic disease.
So putting you on the spot, let's say you have a medical oncologist that wanted to give, their standard was to give 4 cycles of chemotherapy, and they're unconvinced by this data so far. What would you say to that medical oncologist?
So you're saying give the 4 cycles with the radiation rather than giving durva?
Yeah.
Saying I've been doing this
Yeah.
since I was a boy or
And
a girl or whatever.
there's one paper and
Yeah. I would push for using the durva once we have survival data and longer progression-free survival. I would even push harder.
Okay. Jyoti, anything you've learned in the last 6 months of doing this?
I think this study is certainly singular. I mean, it changes the paradigm, but getting back to something that Wally mentioned. I mean, there is now an accumulating body of data to suggest that there is synergism between radiation and immunotherapy. And we are seeing these subsets do better than ever before. And so although it's one study, it kind of stands on the shoulders of a large body of data that really supports this concept.
Again, it's, I think one issue that has come up already is what do you do when somebody has pneumonitis? I was faced with that, and we have two competing causes of that. Easily it could have happened from the concurrent chemotherapy and radiation, but also a patient was on immune checkpoint blockade as well. I think what you have to do, actually the treatment for both is the same.
Right.
So it made it kind of easier, but it was quite a dilemma.
Yeah.
The other question that came up with
the question is whether you'd stop the immune checkpoint.
Right,
That's the toughest part.
That was the exact question
Yeah.
that came up. The one interesting thing, though, is a growing literature that the patients often with the most profound benefits from immune checkpoint blockade that have very serious toxicities have had long-term benefit from just a single dose of these drugs. So it may be that one of them to prime the immune system in a way to attack the cancer, and priming it in such a profound way that pneumonitis came out, it may be that the one dose is good enough, but I mean, that's a unique problem that can come up here.
I think it's interesting. Last week I had 2 cases in which I had patients who had been treated in the community with Durva after chemoradiation, and in both of those patients there was pretty significant pneumonitis, which was closer to the radiation. And so again, we had sort of 2 competing causes. But both patients came, I think, because of the oncologist they were seeing were feeling so guilty about holding the Durva and sort of looking for one person, again, because of these profound PFS gains, to say, it's okay, that we've probably had enough, let's take a little break and continue the steroids.
Yeah, I think just to remind folks that this is a concurrent chemo rads given in the best way is a tough regimen.
Yeah, absolutely.
Looking at that Nasser Hanna trial in the HOG group, sort of a real world statewide or beyond regimen, I believe the number was that just getting concurrent chemo rads alone, 1/3 of the people were hospitalized due to various adverse effects, fevers, pneumonitis. So it's a tough regimen, but in my mind, very justified because of the goal here. If we can cure folks, and then now hopefully with the addition of durvalumab to cure even more people, it's worth pushing the envelope. The question that comes now, I think we have some consensus here that we're going to use this regimen and move forward, but what's the next step here? How are we going to do an even better job for patients, and is there a role for these drugs in patients that either are not getting, I'll ask you first, not getting concurrent chemo rads, but let's say because of a side effect, a patient with severe neuropathy, for example, not getting a chemotherapy regimen, or because of a poor functional status, they would only get radiation?
Well, I'd love to see some trials being done looking at the consolidation durvalumab after some sort of radiation course for people who are medically impaired. And we've only done a fair job at best doing those kind of trials because there's such heterogeneity. And some of the poor performance tests is due to burden of disease, some of it's coexisting conditions, and there are multiple. But I'd love to see a trial where we look at adjuvant durva with either radiation alone or a very attenuated course of concurrent chemotherapy with radiation, because we've made no real progress with those patients. The main progress I've seen is that radiation oncologists have demonstrated for such patients a more hypofractionated regimen of radiation is doable with good symptom management, not too much toxicity. So doing hypofractionated radiation, some sort of chemo and adjuvant durva, I'd love to see that tested.
But in that these patients ultimately face metastatic disease as the biggest risk to their life and health, wouldn't it make more sense to give the durvalumab or other immune checkpoint blockers with the radiation, even in those patients who don't get chemo?
So that's and that's being looked at in a number of studies now, institutional studies, Hoosier Oncology Group, Rutgers, a couple of the groups are looking at it. And that is bring it with the concurrent chemo radiation. One of the tough things about that, Mark, as you said, concurrent chemo radiation is tough. And is there toxicity space to add a third modality, really what we're talking about? Or
I'm talking about adding a second modality to those patients that aren't going to get chemo.
Absolutely, agree with that.
Substituting.
Absolutely agree with that.
Yeah, I think that's a real opportunity to move forward.
No question.
And oh, by the way, do you think that there is any side effect of the immune drugs that's enhanced by radiation, or conversely, any radiation-enhanced side effect that is worsened by the durvalumab or other checkpoint blockers?
You know, the data is still coming out in phase 1 studies. The studies I've seen do not show a dramatically worsened toxicity, but until the studies are done, I don't think we can answer that.
Okay. Jyoti, could you comment a little bit about, for those patients that are candidates for concurrent therapy, can we do a better job with the systemic therapy with the radiation?
Absolutely. I think there are long ways to go still. So again, bringing immunotherapy up during chemoradiation.
Well, I'm sorry, but not so much the immunotherapy, but we're talking about chemo. Are all chemos the same? You think it's generic? And is that a place where we should be investigating? Is there a better chemo?
3 decades later, it's hard for me to say yes, there's a substantial difference. There are, though, little differences, right? So it may be that certain regimens are more tolerable, and so you may be able to get full dose radiation in, patient preference, certainly, but my sense is that there's not going to be a significant difference between different chemotherapeutics. I don't think one is more of a radiation sensitizer than another. It's really about the systemic disease. As we have more patients with oncogene-driven tumors with stage 3 disease, it may be that targeting those with radiation will also be important, and intercalating TKIs with chemotherapy and radiation may still be of interest.
When would you, that was my next question to you, when would you, let's say you found an EGFR exon 19 deletion, what would you do, actually? Let me throw that case out to you. EGFR exon 19 deletion, you knew it on day 1. What would you do?
It's stage 3 disease, and it's still curative. And
but
right now,
it's inoperable and unresectable.
Still curative intent with chemoradiation. And so I would treat that patient with probably cisplatin and pemetrexed and radiation. And with the small amount of data we have, which is in this trial, 5 or 6% of patients had EGFR mutations. With that small number of patients, it looks like there's a benefit to durva. So in the absence of negative trials, I would treat that patient with durva afterwards.
Yeah, I would say that we have to be careful extrapolating from what we know in stage 4 disease to earlier stage disease. And again, I'll throw out the example in the neoadjuvant space. I don't think anybody would have expected the high rate, the rate of pathological response, double that we see with chemotherapy in people getting checkpoint blockers in the setting of neoadjuvant therapy.
And even in never smokers, so we've seen that, right?
They've seen it in never smokers, EGFR mutant cases. It's sort of a different ball game, so you have to be careful with that. So would you ever give an EGFR TKI to one of these persons? What about after they finish the durvalumab?
Is that 2019? We'll have some more data by then.
It'll be a little while. So, hey, Wally, can you just tell us what the radiation oncology community is doing now to take this field forward? Are there trials underway now, or the ones you're involved with, or part of the groups you're affiliated with?
So I'll talk about a couple of trials in stage 3 disease in general, and then specifically with checkpoint inhibitors. One area that I think is very interesting is to doing what's called adaptive design studies, where you actually use what happens to the patient during the course of the trial to influence what you do. We finished enrollment in Energy Oncology, RTOG, of an adaptive design trial where we got a mid-course PET scan and were able to modify the radiation field based on a response to a 3 or 4 week PET. And we don't have the data, but what we did demonstrate is the ability from multiple centers to actually do that. And it could be that those patients where there's a shrinkage would allow us to actually dose escalate those more safely than we could in PET non-responders. Mm-hmm. So that's pretty interesting. There are trials either that are ongoing or in design where we're taking this landmark Pacific trial and using that as the background in the control study and adding checkpoint inhibition during radiation. It really has to be done carefully. It has to be done with sort of dose-limiting toxicity studies before the full randomization takes place. And finally, I agree with, regardless of the fact that induction chemotherapy never added much to concurrent chemoradiation, I still am pushing for the idea of checkpoint inhibition as a window of opportunity for those patients with stage 3 disease who are not so symptomatic that you feel you're risking something by not starting radiation on day 1. I think we could get some of the same exciting data that you're talking about in the operable patients.
Mm-hmm. Yeah, the one thing that we've learned in the neoadjuvant trials too, though, is the lack of a strong correlation between imaging studies and
Right.
pathologic response.
Yeah, right.
If you're going to look at what happens to the lesion in these patients, you have to be very, very careful because we've seen very profound pathologic responses, no question of response, yet no improvement on CT and no improvement or sometimes even increase on PET scans.
Right.
So be very careful there. You mentioned about using your PET scan to help hone in on treatment too. I believe there was some older literature that the PET could somehow be influenced by radiation. Is that true or is that debunked at this point?
No, that's true. But if you're looking at a 3 or 4 week PET, you don't get usually the inflammation. So if you have a 30-day gap between PET 1 and PET 2, you're really going to be looking at biologic response and not the inflammation associated with it you might see within 6 weeks of the end of chemoradiation.
Mm-hmm. Okay. Jyoti, your thoughts about other trials moving forward in the space or questions that you would want to see answered?
So certainly I think, we talked a little bit about surgery up front, but can we intercalate surgery into this paradigm? So are there patients, because half of all patients with resectable stage 3 disease get chemoradiation in the country, right? It's regional or site-specific. Mm-hmm. It's not, we don't have the best answer. But would there be a scenario in which we treat patients with chemoradiation and then they undergo resection and then they are treated with immunotherapy? There's an ongoing study through the Hoosier Cancer Network that's looking at pembrolizumab in that setting. Allocating appropriate therapy to those that were not in this trial. So unfit patients or patients with comorbidities, I think, is a huge unmet need. Because if we look at traditional, and this trial again was a little bit different because patients were randomized after treatment of therapy or after concurrent chemoradiation. But if we look at the proportion of patients in the United States with locally advanced disease who are eligible for our current clinical trials, it's a minority still, who have pristine pulmonary function and performance status and lack of weight loss. So we're really looking at a subset of the patients that we need to do better for.
Yeah, just a caveat to those thoughts. The first is I'm still unaware of any evidence that an induction therapy of any kind makes unresectable people resectable. I mean, that is, people have said this, but there is no data to do that. And I think I would be very, very careful in 2018 to have a multidisciplinary decision and to make a clear decision whether somebody is resectable or not. And if a patient is resectable, they're resectable that day. And if they're not, they should get concurrent chemoradiation, because for you to be faced with somebody after some induction chemotherapy and then have a decision not to proceed with surgery, I believe that compromises your ability to deliver a curative dose of a curative therapy program. And I'd be really, really careful about that. Again, coming back to the need for multimodality discussion and a clear multimodality plan. I see these cases all the time at our tumor board. People come to our place from other institutions, and that decision-making process hasn't happened. And I can't emphasize enough to put your team together and work something out, make up a plan and stick with it. Obviously, the condition can change, but the overall plan should change.
But having clarity early on, as you're describing, I think is very helpful to the patient and his or her family as well.
Absolutely.
Yeah. So let's go now to some of the questions that have come in, and we'll do our best to answer them. I think the first one, and it's probably a great place to start, and we'll probably end on that too, is are patients really cured by this? Wally?
So chemoradiation cures people. We've often used the 5-year survival benchmark as an important benchmark, and we're now seeing over 20% of these selected patients who are alive at 5 years. Some of them will be cured, and cure is a tough word, but if you're without evidence of progression disease and living a good life after 5 years, I'm happy the therapy's done its job.
Yeah, and I think for the record, I trust the data will bear this out, that there are very few, I know the surgical data better than the chemo rads, but there are very few recurrences after the 3rd year, frankly.
Yeah.
And the other thing to please remember now that we have these long survivors, they're also at risk for second primary lung cancers.
Correct.
So that tumor nodule that pops up 5 years afterward under surveillance, it's more likely to be another primary lung cancer that needs another primary therapy approach.
Yep.
Jyoti, as the medical oncologist, is there a role for bevacizumab in patients receiving radiation?
So it's been a checkered past, certainly. There were initially some studies looking at radiation to sort of palliate local symptoms, normalize blood supply, and give bevacizumab to patients with squamous cancer. That failed with a high degree of pulmonary hemorrhage. In patients who were getting chemoradiation and non-squamous, there were higher rates of T fistulas and, again, more toxicity. So at this juncture, I think most of us have abandoned any idea of bringing bevacizumab into the chemoradiation space. But we are also now looking at checkpoint inhibitors with anti-VEGF, and so it may be that out back there may be a role, and that may be investigated in the future.
And what about ramucirumab?
And certainly ramucirumab has efficacy with these checkpoint inhibitors, ramucirumab with radiation. I would be pretty nervous about, and I think it's the same ideas that we're seeing higher rates of fistula formation and esophagitis.
Is that across all cancers or in lung particular?
In lung particularly, I don't know about esophageal.
I don't know data elsewhere with ramucirumab. Bevacizumab issues were across many disease sites and types of cancer.
And I think the data too was that I think people thought that if you gave some radiation, then it would be safe to give bevacizumab, and that really didn't pan out in the few trials that were done. Just a very practical question. Do you ask for, as you would in a stage 4 patient, upfront, complete genotyping on a multiplex panel? Do you ask for that in a stage 3B patient that is inoperable and unresectable?
So I think it's an institutional practice. So certainly at my institution, we do reflex testing in all patients who are diagnosed as part of an institutional research effort. And practically speaking, for patients with potentially curative therapy, from stage 1 to stage 3, it should not influence your decision making. And so sometimes you may get it early on as part of the diagnostic workup, but then lo and behold, the PET looks better than you thought, or the the axillary lymph node ends up being reactive and benign, and so you may have that information. At this juncture, I don't think we know how tumor mutation burden, for example, fits into these patients. Are there patients that will benefit more with checkpoint inhibitors after radiation? I don't know. So at this juncture, probably not. It doesn't fit into my treatment paradigm.
And if a patient was referred to you from another institution and then they did not have adequate tissue for multiplex testing, would you do a rebiopsy at this point?
No, not if I was planning to treat them with curative intent.
Wally, what's the paradigm at Emory?
It's similar. We don't do we do a 20 gene panel on all patients regardless of stage, and we have that as a reference. What I can tell you is it's been challenging to do trials even on a national basis that involve any kind of molecular testing for stage 3 patients. Energy and Alliance came together to do a randomized phase 2 trial looking only at those with EGFR or ALK mutations, looking at an ALK inhibitor or an EGFR inhibitor in addition to chemoradiation. And we did not complete enrollment, and the main reason was that the lack of testing of those patients at the institution, number one, or the perception that there are fewer mutated patients in the stage 3 than the stage 4 cohort. And I think it's actually a combination of both. And we're seeing that in the Alchemist trial with the ALK mutation.
It's tough because all we do is spend all day telling people to get mutation testing,
Right.
before you treat,
Yeah.
and then in this setting that's 3B as close as you can get, we're backing away from it. So
Well,
it's tough.
I have to say, Wally, I share your experience there. I think perhaps the only time in my medical career that I had to send back a grant was a grant to give afatinib with concurrent chemotherapy and radiation that we had. That said, though, this paradigm is changing quickly.
Yeah, I agree.
Because more and more people, as part of the initial biopsy, are getting a next-gen panel, as I think all the panelists are doing at their institutions. But B, blood-based testing has changed that as well. Right. So I think if you wanted to do that trial now, and you had blood-based testing, you could.
I agree.
The other thing to people that would like to do this, and we really didn't have it at the time, is our pathologists routinely do immunohistochemical studies for EGFR, L858R, and ALK. Every time they get a diagnosis of lung cancer handed to them, it's reflexively reported and PD-L1.
Right.
So within 48 hours, we have that data, and we could refer somebody for that kind of a trial.
Great.
Hey, what about giving a immune checkpoint blocker with SBRT today?
So SBRT stands for the stereotactic radiation. The answer is being done as part of trials at several centers, including our own, and proceed with caution outside a trial. There are people with metastatic disease, be it melanoma, lung or other diseases, where they are going to be on a checkpoint inhibitor and they are going to need SBRT. I like to be careful, but based on what I've seen clinically and what I've read, I have not seen undue toxicity, and there is the opportunity for synergism.
Can I ask make a comment on that report in GEM Oncology about the increased risk of radium necrosis in people getting SBRT for CNS lesions?
Yeah, that's interesting. We haven't seen that, but it's something we need to watch for. The reality is radiation necrosis inside a lesion is really what you're after with stereotactic radiation. What you don't want is necrosis outside the lesion. What you're probably learning in that is the kind of doses we give with brain radiosurgery, and a patient who has immune checkpoint inhibitor response is probably more therapy than they need to kill the lesion. So we have to kind of back down on something.
Another piece that I think is interesting of using SBRT in patients with metastatic disease and immunotherapy.
Right.
Often SBRT is utilized for patients with oligometastatic
Correct.
disease. And and those patients seem to have a higher PD-L1 and may be analogous to those early stage patients that you're talking about. That may be
Right,
something
correct.
that the immune system is doing to keep the cancer in check. So
Yeah.
clinically, they've seemed to have a higher response. Again,
Yep.
proceed with caution in non-clinical trials, but
Yes.
there may be something there.
I
Yeah,
agree.
one critique I had of that paper is they focused on radium necrosis, but they didn't talk about the long-term outcome of those
No.
patients.
Which could have
And
been
again,
great.
But we're talking about, and perhaps when, again, these solid tumor metastases, these patients can sometimes be cured.
There's
Yeah,
your use of bevacizumab.
And that's my use of bevacizumab, and I'd be very, very careful with that. A question came in, Jyoti, let me ask you, what do you do with a patient who progresses while they're on the durvalumab? Who develops, let's say it's a new liver metastasis, let's make it.
So I think this would be
clear-cut.
back to the drawing board. It would be, again, going back to what we know, a biopsy of that lesion. If that tumor was high PD-L1, I would treat that patient with chemotherapy. if they
But what
progressed.
about while they're on?
So on durvalumab, I would rebiopsy if there was evidence of progression. And probably, again, reflexively, we would get the PD-L1 at our institution, but if they progressed on durvalumab, I would go to chemotherapy or a clinical trial.
And what about after?
Right, so the duration of 12 months, I don't know how long is the right amount.
Well, let me pick a number. A year after stopping the durvalumab, then you have the liver metastasis.
Then I would rebiopsy, and if high PDL, absolutely treat with
And if so you treat them like a newly diagnosed stage 4
like de
patient.
novo,
Yeah.
exactly.
I think that makes some sense. I think most people
But if they
would do that.
progress 2 months after stopping, would I restart? Probably.
Okay. All right, so again, and another question that came up about what is your routine for rescanning these patients? So your patient completes chemo RT. How quickly after the end of the completion of chemotherapy and radiation do you normally rescan?
My practice
In the
is,
absence of symptoms, by the way.
yeah, my practice would be 6 to 8 weeks after chemo radiation. That gives me, in what I view as the best window to look at imaging response to the chemo radiation. It's given time to respond, and it's before we start seeing some significant scarring in the radiation field.
Okay, Josie, what about you?
I don't think that we really have good guidance. It tends to be sort of institutionally directed. Traditionally, I've looked between 4 and 6 weeks, and that will likely change as more and more patients are treated on Durva. But again, this is where that clinical hat really comes into play, that you have to be comfortable that your patients have recovered from all toxicity before you initiate therapy, and then really be tuned in with your advanced care providers, with your nurses, with your entire clinical staff when you're treating these patients every 2 weeks for a year, that you're doing thorough review of systems, looking for the weird toxicities that can happen.
Yes, so our institution generally does not do another imaging study in the absence of the durvalumab for usually 3 to 4 months after the conclusion of radiation. I think in an asymptomatic patient, that is largely to get away from the process of recovery, I'll call it, that scarring that follows, and not to get confused by that. And somebody, again, who is fit, obviously if somebody is unwell, then you would need to consider doing an imaging study much sooner. We've had a lot of new issues to deal with, but I hope everybody will agree that they've been the kind of things we want to deal with.
Exactly.
Trying to find a way to deliver an important therapy to more patients. And again, the estimation is we're talking almost 50,000 people a year in the United States that could benefit from this therapy. So it's just a great opportunity for thoracic surgeons, medical oncologists, radiation oncologists to really make a huge difference here. And this is, you know, as much as we're very proud of what's happened in people with more advanced disease, and we've led to a lot of longer and better lives, this is a step even beyond that, longer, better, and maybe even cured. You know, it's just amazing to me now that I've cared for people long enough that they got second primary cancers, and then I've got a chance to cure them again, things that I never thought would have been possible. So this has been a great discussion. Thank you. I thank you also for your candor and your experience, and you know, I think folks really want to know what you do, and you were very, very clear about that. We hope that you've all found this information valuable to you and valuable to the care of your patients, and that hopefully at least some of it you'll be able to put into practice later this week. Thank you for watching OncLive News Network.